Today we will go through the paper titled Case Report, Absent Fluorodeoxyglucose Uptake in a Dog with Unexpected Brain Death. This is from Frontiers in Veterinary Science from December 2022. It is open source, so let's get through it.
Case report, absent fluorodeoxyglucose uptake in a dog with unexpected brain death. A 5-year-old male Maltese dog was presented with generalized tonic seizures and hypermetria. Multiple nodular subcortical cerebellar enhancements and meningeal enhancement were observed on magnetic resonance imaging. Fluorodeoxyglucose positron emission tomography/computed tomography was performed due to suspicion of neoplastic disease, and no fluorodeoxyglucose uptake was observed in the intracranial structures. In PET images of this dog, absent fluorodeoxyglucose uptake was identified in the brain, indicating no cerebral metabolism, strongly suggested brain death. The dog had no spontaneous breathing and no brainstem reflexes for more than 24 hours after the termination of anesthesia. Through these results, this dog was diagnosed with unexpected brain death, and it is presumed that the cause was anesthesia. We report herein a case of brain death in a dog diagnosed using fluorodeoxyglucose positron emission tomography/computed tomography. Introduction. Brain death is defined as the irreversible and complete loss of all activities of the brain, brainstem, and cerebellum resulting from the cessation of cerebral perfusion caused by increased intracranial pressure. The diagnosis of brain death is primarily clinical, that is, it involves a single apnea test and 2 assessments of brainstem reflexes. Exclusion criteria for the diagnosis of brain death include hypothermia, shock, brainstem encephalitis, Guillain-Barré syndrome, encephalopathy associated with hepatic failure, uremia and hyperosmolar coma, severe hypophosphatemia, and drugs known to alter neurologic and neuromuscular function and electroencephalographic testing. Brain death can be diagnosed through ancillary tests when a clinical examination is not fully possible. Electroencephalography, cerebral angiography, nuclear scan, transcranial Doppler, computed tomography angiography, and magnetic resonance angiography are ancillary tests currently used to determine brain death. Human patients diagnosed with brain death using a fluorodeoxyglucose positron emission tomography scan, which is a nuclear scan, have been reported. A hallmark of the FDG PET scan for brain death is the absence of tracer residues within the brain and brainstem, indicating the absence of brain metabolism. Furthermore, in a study using brain-dead experimental animals, FDG PET was used to confirm brain death. To the author's knowledge, there have been neither reports of brain death in canine patients in clinical veterinary medicine, nor of canine patients diagnosed with brain death using FDG PET. Case description. A 5-year-old male Maltese dog was admitted with hypermetria that started 3 days prior and generalized tonic cluster seizures lasting 3 minutes. It was confirmed through the history taking that the dog had not been admitted to other veterinary clinics for the neurologic symptom, and that this dog had never been under general anesthetized. Hypermetria of both thoracic limbs as cerebellar ataxia was identified through neurological examination. Abnormal findings were not identified in the blood test, and it was confirmed that general anesthesia was acceptable for the canine patient. Multiple nodular subcortical cerebellar enhancements and meningeal enhancements in the cerebellum and cervical spinal cord were observed on contrast magnetic resonance imaging. Although this MRI pattern has never been reported in dogs, this MRI pattern has been reported as a metastatic lesion in humans. Therefore, screening for primary tumor and evaluation of cerebellar lesion in this case was required. PET computed tomography was performed immediately after MRI to screen for primary or metastatic brain tumors. PET CT images were obtained approximately 60 minutes after intravenous administration of 6.3 mg/kg per kilogram fluorodeoxyglucose. The PET CT images showed an absence of FDG uptake in the intracranial structures. To investigate the metabolism in the brain, standardized uptake values, which is used to normalize tissue FDG concentration relative to the injected dose and body weight, were compared with other extracranial structures. The estimated mean SUVs of the cerebrum, brainstem, and cerebellum were lower than those of the cervical spinal cord, trapezius muscle, and both eyes. With the exception of intracranial structures, FDG uptake was identified in the whole body, and indications of a neoplastic lesion were not observed. For MRI and PET CT scans, general anesthesia was performed for a total of 3H, and major vital signs were measured at 5-minute intervals. The ranges of the vital signs that were monitored during anesthesia were as follows: heart rate, 90 to 120, respiratory rate, 12, body temperature, 36.5 38.1, systolic blood pressure, 105 to 145, end-tidal carbon dioxide, 3544, saturation of percutaneous oxygen, 97-100. Following anesthesia termination, the canine patient was found to be in an irreversible coma, with the absence of all cranial nerve reflexes, including pupillary light reflex, oculocephalic reflex, corneal reflex, facial muscle movement to noxious stimulus, and pharyngeal reflex. In the absence of spontaneous respiration, mechanical ventilation was maintained. The canine patient remained in an irreversible coma for 24 hours the next day. At the request of the owner, the canine patient was euthanized, and we did not perform a post-mortem examination. Discussion. Brain death in human patients accounts for approximately 5% of pediatric and 2% of adult in-hospital deaths in the United States. However, to the author's knowledge, there have been no reports of brain death in canine patients due to diagnostic limitations. Scintigraphy is an inexpensive and non-invasive examination used to determine brain death in human patients. Ozdemir suggested that FDG PET CT could be used for the confirmation of brain death because it has higher spatial resolution compared to other nuclear scans, such as gamma camera and single photon emission computed tomography. In this comatose canine patient without spontaneous breathing, we suspected brain death due to the absence of brainstem reflexes including the pupillary light reflex, oculocephalic reflex, corneal reflex, facial muscle movement to noxious stimulus, and pharyngeal and tracheal reflex. The absence of brainstem reflexes is considered to be one of the diagnostic criteria for brain death in human patients. In addition, the absence of FDG uptake in intracranial structures, an indicator also used on the FDG PET scans of brain-dead human patients was identified in this canine patient. A previous study reported that extremely low FDG uptake was identified in the brain in human patients with metastatic neuroblastomas. However, no neurological symptoms were observed in those patients. In our case, since this canine patient showed an absence of all brainstem reflexes, the possibility of neuroblastoma was considered to be very low. It is suggested of a 6H observation period after the first clinical examination is reasonable and sufficient for clinical manifestations and consistent with the diagnosis of brain death. After the canine patient was confirmed as brain dead, a neurologic examination was performed every 12H for 24H, and the results of the second examination were the same as those of the first. Therefore, this canine patient was determined to be in an irreversible coma. As histopathology was not performed in this case, the disease resulting in the distinct lesion observed on the MRI scan could not be identified. Although an obvious lesion was not observed on the MRI scan, brainstem encephalitis could not be completely excluded. It has been reported that in the cases of human brainstem encephalitis such as Fisher syndrome, increased FDG uptake in the lesions were identified on PET scans. Therefore, the possibility of brainstem encephalitis, which was one of the exclusion criteria for the determination of brain death, was excluded in this case because FDG uptake was absent in the brain of this canine patient. Other exclusion criteria, including hypothermia, shock, encephalopathy with hepatic failure, uremia and hyperosmolar coma, and severe hypophosphatemia, were excluded in this case due to normal results of the physical examination and blood analysis before the anesthesia. Furthermore, changes in vital signs and saturation of percutaneous oxygen and end-tidal carbon dioxide were not observed during or after anesthesia. Therefore, brain death was confirmed in this canine patient. It has been shown that the complication rate due to anesthesia is higher in canine patients with brain lesions than in canine patients without brain lesions due to the increase in intracranial pressure following anesthesia. Several reports have suggested that brain death can occur during anesthesia. The exact cause of brain death in this canine patient was not identified. However, we suspected that the cause was an anesthesia-induced increase in intracranial pressure followed by brain damage. This report has several limitations. First, the apnea test, one of the tests used to confirm brain death, was not performed in this canine patient due to failure of arterial catheter placement. Second, other ancillary tests used to determine brain death, including electroencephalography, cerebral angiography, transcranial Doppler, computed tomography angiography, magnetic resonance angiography, and brainstem auditory evoked response, were not performed. Third, intracranial disease, which may have been related to brain death in this canine patient, was not diagnosed through histopathology. In this case, unexpected brain death was confirmed in the canine patient through the absence of all cranial nerve reflexes, as well as the absence of FDG uptake in the brain, a marker for the absence of brain metabolism. This report described the diagnosis of brain death in a canine patient for the first time in clinical veterinary medicine, and described the features of FDG PET-CT of brain death in a canine patient.
To run through the article, full disclosure, my knowledge of PET is limited. The marker used, FDG, is a marker used to look for energy consumption. As the name includes glucose, if there is an area of high glucose uptake, such as with a tumor, then there would be more uptake of the FDG, and therefore that region would light up, per se, on PET scan. Additionally, if there is an area of low glucose uptake, such as a seizure focus, then there would not be uptake of the FDG. So looking at figure 1C, it's a sagittal of just the PET itself, and then D is the PET combined with CT. Hopefully you can appreciate that there are darker regions, at least on image C, or the more yellow regions on image D. Therefore, there's more uptake of the FDG, and where there's no uptake, so either the white areas or just areas where there's no signal, then again, there's no uptake in that region. As the brain generally uses a lot of glucose, there should always be some uptake of the FDG. Therefore, this patient became brain dead sometime after induction, but before the PET scan. There is still blood flow getting to the brain as there's contrast uptake on MRI, so it's not a blood flow issue, I don't feel, as far as why this patient became brain dead. Looking at the MRI, nothing about it says increased intracranial pressure to me, and there's nothing provided throughout the history that makes me feel that this dog had an increased intracranial pressure, such as the patient becoming hypertensive with bradycardia. In the discussion, they stated that the dog likely died because of increased intracranial pressure from the anesthesia, but I feel we cannot draw this conclusion. It is possible that, again, it could be the increased intracranial pressure, but it also could be an idiosyncratic reaction from one of the medications, progression of the disease, decompensation from the disease because of anesthesia, or multifactorial. Given the signalment of the patient, examination findings, and the MRI findings, I suspect idiopathic generalized tremor syndrome. The paper states that this MRI pattern has not been reported in dogs, but at least some of the findings have, perhaps maybe not with the cerebellar enhancement, with the cervical spinal cord enhancement as well. Although I agree with the findings of the paper and that the patient is brain dead, it would have been nice to either have EEG or Bayer to have another way of confirming the diagnosis. The paper does provide good information, seeing what a brain dead patient would look like on FDG with PET scan, but of course the question is, why did this patient die? Those are my thoughts. Thank you.